Welcome back to the RT Clinic. Today's video, I'm talking about using a glide scope for video-assisted intubation. Let's go. So today we're going to look at video-assisted laryngoscopy. We're going to use a video system to intubate the patient. And so this is a little bit different than if you're doing direct laryngoscopy that we use a blade with that we have talked about in the past. This is one type of device. It's called a glide scope. There are many on the market, but when you go to intubate the patient with this, this is not the same technique as direct laryngoscopy. There are a couple key points that you need to follow so that the endotracheal tube gets to the right place as quick as possible. Let's take a look. So I got you up close here on Fred the Head, and we're going to show a little bit about how to use video laryngoscopy. So first of all, we're going to turn the device on. On this device, you're going to see it comes out, it has a camera on the end. On the end of this camera is a light. Obviously, you need a light. It's a dark area down there. And then the tip actually warms up a little bit. When the tip warms up, it then allows it not to fog when it goes inside of the oral pharynx. We're going to use a device called a GVL. This is just specific for this type of device. This is a disposable piece. It acts like the blade. You notice it's kind of rigid, and the light actually goes inside of it, and it's held like this. So we have light on. Everything is ready here. We'll leave this inside of the package just so we're not getting a lot of things on it. Another piece that's going to be different than with direct laryngoscopy is you're going to use a rigid stylet. And this rigid stylet, I want to compare this. You can see it doesn't bend at all. It actually has this piece on the back right here, and it almost acts like a joystick. And I'll show you a little bit about how that works once we put the endotracheal tube in. A standard stylet, just for review, is semi-rigid. And it looks something like this, but can be bent to whatever angle we would like. And so we usually use that with direct laryngoscopy. Not in this case, so we're not going to use that one. Let's go with an endotracheal tube. Obviously, it's going to be done the exact same way. And the endotracheal tube, in this case, I'm using a smaller one just for demonstration purposes. Just like any other time you're going to intubate, you're going to want to make sure you check your pilot balloon first to make sure it properly functions. You do that by inserting 10 mLs of air into it. It seems to hold, and then my case, I always just leave this attached. Insert the rigid stylet inside the endotracheal tube. As it goes down, you see it ends just before the Murphy's eye, but it's all the way to the hub, so that's exactly where you're going to put it each time. So this is ready to go. Probably going to use some lubricant, maybe keep this inserted inside the package so we can do our intubation. Now, we're not going to show any of the pre-ventilation aspect of it. We're going to get straight into it. You're going to notice we have a camera over on this side. A lot of times this will face the person intubating. Direct laryngoscopy, I'm going to visualize and I'm going to insert. With video, it allows that extra level of I can see it go in and everybody in the room can see it go in. It gives an extra level of comfort to everybody to know that endotracheal tube's in the right spot. Obviously, you'll still want to check that with XL capnography or colorimetric change if you have that. Capnography is the best option for that. So just like with intubating as we do direct, it's going to go in my left hand every time. If we were doing direct on this patient, we would probably start on the patient's right side and then kind of sweep a little bit. This is a lot different. This has to go straight down the center. And when it goes straight down the center, it's going to look at something like this from this piece of equipment right here. It's going to slide straight down the center. And you see how it's nice with the curvature with the tongue. It kind of goes around the corner. And then it's going to act like a hook and kind of and then you're going to pull upward on it. So up this way, and it's going to lift that soft tissue up. So you're just thinking about riding right along the tongue going down and lifting and being able to visualize. Now you can see over there on the monitor, that's beautiful, right? That is wonderful. Whew. If it only looked that good. So that's exactly what I'm going to be doing with this mannequin. So I'm going to have the patient prepared, left hand obviously gloved. I'm going to go straight down the center. You may have to get around a sticky tongue here or there. So I'm going straight down, and you notice I'm going to go straight down and around the corner to about here. So it kind of goes around the corner, and now I'm in the oral pharynx. You can see it on the monitor, not seeing a whole lot. If you look down low down there, that's way into the dark. That's the esophagus. But I'm going to go in like this, and then I'm going to lift up. I'm not going to crank back. You can do a little bit, but you're going to put too much pressure on the teeth. You want to lift up. So go straight down, lift up. Wow, look at that. I can see beautiful cords right there. This is one of the frustrating parts is sometimes you'll see beautiful cords and you'll have trouble getting the endotracheal tube in. Because of the rigid stylet, this is something you have to practice before you use it on a patient. It can go very quickly if you know what you're doing, but if not, you're going to struggle a lot. Now that I have this in, I'm going to take my endotracheal tube and I'm going to go just the angle like this. I'm not going like this. I'm not going like this. I'm going at a 90-degree angle. I'm going to go in. And then I'm going to do this. I'm going to rotate it up. So it goes like this, in and rotates up. And you're going to see that come into view in just a second. So 90-degree angle to the face, in and rotate up. Now I'm going to grab it right here. I'm not going to go down here. I'm going to grab it right here when I go to lift. Now you notice there's the cuff. You can see it on the monitor, and you can also see the cords. So most cases you would think, I'm just going to push this in. Well, what happens if I'm just pushing straight down in? It's trying to actually go below, and you see if I work it enough, I can actually go, oh, that's bad. Don't go into the esophagus down there. It's much more of a finesse that you're going to do when you insert this. So you're going to go in with the blade down the center. You're going to rotate in. You're going to go up to the joystick, okay? Now, watch my thumb up here manipulating the joystick. So I'm going to manipulate the joystick. If I'm down here, I'm going to push this way, and it moves it. You see it moves back and forth in here. You're going to use that manipulation of this joystick to get it to go to the right spot. So let's start from the beginning again. Straight down the center. Visualize. I see it. Next one in, 90-degree angle, around the corner. Go up to the joystick. Oh, I'm on the side. I'm going to push to my right and then insert. And you can see it's starting to go in the cord. You can see it's starting to go in the cord. It's going to the right spot. But I get to this point right here, and I keep pushing, and it actually meets a lot of resistance. I have a lot of resistance right here. This is the key to using this. At this point, you have to pop this up. So you're going to have it down, you're going to pop it up like this, and you're going to kind of insert the tube this way. Okay, tube is past the cords. I'm going to remove the stylet, but I'm not going to pull it straight out because it's rigid. It always goes down towards the chest. So it comes out, goes towards the chest. At this point, I can visualize the vocal cords. I see endotracheal in. Everybody in the room can also see this going on if it's this beautiful. And now I can start to ventilate the patient. Inflate the cuff, then ventilate the patient. So that's a quick little rundown of those parts and pieces that you're going to have. Remember, this is a rigid stylet. And let's go over it one more time, how to insert this correctly. First, number one, straight down the center. Grab it like this. Visualize the cords. So I lift it up, boom, wide open. You can see them right there. Second one in, I'm going to look at the mouth again. So I'm looking at the mouth, I'm lifting, I see it, look at the monitor. Look back at the mouth, insert this, look back at the monitor. If you're looking at the monitor while you're trying to insert this tube in up here, you might have trouble. So let's just review this again. First of all, I'm looking at the mouth, inserting directly down the center. There's step one, okay? Step two is I'm looking over at the monitor, I find the cords. Step two. Step 3, as I look back at the mouth. So we're going mouth, monitor, mouth, monitor. So mouth, monitor, back to the mouth to insert the endotracheal tube, 90-degree angle, and rotate in. Grab this piece right here. I'm going back to the monitor now. Now I can start to control it. I control it with my thumb on this, what I would call a joystick. I insert it to here. I'm still on the monitor. At this point, I'm in the cord. I'm getting past the cords. Not past them yet. I'm going to pop this up. You can see right there on that monitor the end of that rigid stylet coming up, and it makes the end of the tube very flimsy and allows it to go in. So sometimes they'll pop up and push in a little bit. Now I'm ready to remove. Remove out. Go towards the chest when I remove out. Don't go straight up because it's rigid. Out towards the chest. Inflate and ventilate. And so that's the key. If I want to check an endotracheal tube, let's say EMS has brought a patient in with the endotracheal tube in, very quick, you just go straight down the center, obviously secure your ET tube, down the center, take a look, okay, we're in the right spot. Everybody in the room can see that we're in the right spot. Vocal cords, there we go. Definitely in the right spot in this case. Verifying tube placement. That is actually number one way to verify tube placement is watching it go through the cords. Now everybody can actually see that it's gone into the cords. So you can see right there, down into the trachea, we are good to go. And now you shut the monitor off. This has the ability to video if you have any difficult airway or you want to use it for teaching or anything on those lines. But now our endotracheal tube's in and we can ventilate through it. One more time through, just for review. For some reason, I'm rhyming everything today. Everything's prepared. Step 1, look at the mouth. Insert, go around the corner. Step 2, look at the monitor. Adjust, lift, adjust until I see the vocal cords. Step 3, look back at the mouth. Insert, endotracheal tube at a 90-degree angle, and then rotate up. Grab the joystick. Step 4, look back at the monitor and adjust, insert, pop, push, pop, push, pull it all the way out towards the chest. Remove, inflate cuff, inflate, and then ventilate. Let me show you real quick what that looks like when we pull the stylet out of the endotracheal tube. And I think this is the number one area that gets missed. So if this is in, right now you can see I don't have a lot of bend on it. So this goes inside the cords and it just kind of pushes. It actually pushes on the bottom aspect of the cords. And the more I push, the more it bends the stylet. That's how you know if somebody's using a glide scope and they don't know what they're doing, this thing is going to come out. Even a rigid stylet's going to bend in the wrong direction. But if I go like this and I'm inside the cords and I push this up, popped it up, you can see it makes the end of the tube, especially if it's warm down there, it's going to be able to bend. And so it's going to be able to bend and turn into the trachea. And then I'm going to take it out here. So by popping that up, it gives you more flexibility at the tip so that that can insert in and then you can withdraw. Make sure you withdraw always towards the chest. I hope this was a good video for you today. Make sure that you're practicing using this. Don't just think you can pick it up and then be able to intubate a patient just because it's video assisted, because there is a different method for viewing and inserting the tube with video assisted laryngoscopy compared to direct laryngoscopy. Make sure to like and subscribe. Look at some merch down below. I also have badge buddies if you're interested in on my website. That's rt-clinic.com, and I will see you later.